Well, good morning, everybody. I'm Professor Shukla from Jaipur, and I'm the General Secretary of the National Pediatric Orthodontist Establishment Society. Dr. Dadia is present here. He is the past president, and we have others, members. Now, we will be talking on amblyopia. This instruction course is basically on amblyopia. Now, I have two talks, so I would first talk on diagnosis of amblyopia. Now, in simpler terms, what is amblyopia? You see, amblyopia is diminished vision in an apparently normal eye with a normal fundus. It is a very simple and very clear cut. It is not a disease of the eye because the fundus is normal and the eye looks normal, apparently normal, but a developmental neurovisual dysfunction. It is not a disease. Now, this is a conventional definition. It has been in place for decades, but there is a problem, because questions could be asked, so let me clarify in the beginning only. In deprivation amblyopia, when we talk of deprivation amblyopia, it means there is something in the visual axis. There lies a pathology in line of vision, whether it is in the lens or vitreous or cornea, and thus rethinking is now underway to remodel the definition. I'm just telling you because you could be confused when you talk of deprivation amblyopia. Now, anyway, we diagnose amblyopia on three basic grounds. Anisometropic amblyopia, where there is a disparity in the refraction between the two eyes; strabismic amblyopia, where there is a misalignment of the eyes; and deprivation amblyopia, where there is an impediment in the line of vision. Now, in anisometropic, I've told you already, asymmetric refractive error in the two eyes creates a blurred image on the retina of the bad eye, which is not resolved by the brain because of the disparity, and thus is neglected. Also, inhibitory responses from the monoocular cortical cells of the good eye suppress the cortical cells of the other eye, because you see there cannot be a disparity, because they would not fuse. This is, but I've just told you in very short. In strabismic amblyopia, there is both an element of diplopia as well as confusion. You see, you should, because this is basic, I'm not going through that. Thus, there is an immediate suppression of the cortical cells of the affected eye, both ways, to remove confusion and also to remove the diplopia. In deprivation amblyopia, the deformed image from the retina is not resolved by the brain, and to enjoy a clear image from the good eye, the second image is immediately suppressed. It is a very simple understanding of the three types of amblyopia. Now, if you have suspected that the patient has an amblyopia, how do you diagnose? There are various modes of diagnosis. One is vision, then neutral density filter, afferent pupillary defect. It is very subtle, but you have to be very careful when you try to elicit APT. Crowding phenomena, normal fundus, central suppression scotoma, which you have to diagnose by certain tests, loss of stereopsis, rotation of nystagmus, four-point diastase, and loss of contrast. These are all the things which happen, and some of these you do not require to do it in a Newton. Sometimes the amblyopia is so obvious that you don't need it, but in case where there is a doubt, you have to go all three steps. Now, vision evaluation, difference of two lines, best corrected between the two lines is, gives you diagnosis, everything else is normal. Refractive error should be assessed with full cycloplegic correction, and which should be an aged, matched cycloplegic to use. We just discussed a few minutes back, what you have to do. Post-cycloplegic assessment should be done very carefully, because one or two lines you may miss. Astigmatism, if you have not seen correctly, and you have not diagnosed correctly, and you have not given a proper access, 1 or 2 lines difference can occur. This has happened in number of cases. A lot of patients have been referred to me by an ophthalmologist that the patient is not, you see, the vision is not coming normal, and he might have amblyopia. They sent to me for amblyopia treatment, and the vision was normal because it was not refracted properly and not corrected properly. See, so refraction is not a child's play. There's a book which I have written 3 years back, which is available in JP Brothers, Correction of Refractive Errors in Spectacle, Giving of Spectacles. It's a full book. It is available in JP Brothers, this thing, which I have very clearly said that please, 50% of the patients come with you in the outdoor for refraction, especially children, So you have to be very careful in choosing the cycloplegic, doing a refraction, and also giving a proper post-cycloplegic specs. Now, this is what a patient sees when you do his test of an amblyopia. This is a very cardinal sign, which you must see. If you put an E, the first letter on the thing, and you tell the patient to look at it with the amblyopic eye, you naturally close the other eye, and you put your refractive lenses, and you tell him to look. This is what it happens in the E. Some of the portions of the E would disappear, come back again. Some others would disappear, they come back again. This is a very cardinal sign. We should very carefully deal. Just because you start from below, 6 से आप start करते हैं, 6 9 6 12 आया और इसके बाद तो improve ही नहीं हो रही. You start from the top. You have to start from the top and see this phenomena. Neutral density. What is a neutral density filter? These are colored glasses, which decrease the wavelength of all lights. So when placed in front of the amblyopic eye, decrease the visual acuity by few lines. But will have a minimal effect, hardly 1 line on a normal eye. At least 3 to 4 lines defect will occur if you put a new, because this decreases the the intensity of light going into the eye. Well, I'm sorry, the photo is not coming. Anyway, afferent pupillary defect, you all know, which you have to do little carefully. Crowding phenomena, another one of salient cardinal sign. A patient is able to read a single letter or the isolated rather than letters capped with letters on the sides. Because if you tell the patient to read a line, the amblyopic patient will not be able to read a line. If you give him a single letter, he will be able to read it. This is a crowding phenomena because the cortical cells are not able to distinguish very closely because the cortical cells nearby have not developed. It's over. Normal fundus, I'm sorry, because I didn't know that there's a central suppression. So we have to see Worth 4 dot test. Distance and near, Bagolini glasses, you can see a central scotoma. It's very clear. This is what you have to do both ways. This is for distance. The left one is for distance, and the other one is torch we have, which is for near. Because if there's a large scotoma, you will not able to differentiate distance. But when you bring the Worth 4 dot test for near at 1 meter, the patient might able to read it. These are Bagolini glasses, very simple. There is a cross, 135 degrees, 45 degrees, there's a cross. There's an opening in the between, that means that eye is amblyoptic. There's a suppression, small, but these are to detect small suppression scotomas. A very simple test. Here it is. You have a pointer. See, this also you can use colored glasses, red and green. It is a modified Bagolini, they can use colored glasses, This is how you will see if there is an total amblyopia in one eye, there's a large suppression scotoma, you will see only this thing or with the left hand, whichever the eye is amblyopic. The normal is this. Stereopsis, we all know, and any stereopsis, we have in a child of say 1 year, we have stereopsis about 400 seconds of arc, it gradually develops up to 5 years, and then this is one of the prognostic values, because if the stereopsis is developing good, vision is improving, that means the patient is improving and as your treatment is successful. You see, this is difficult to know, but you can do a doll's eye phenomena, which is a oculocephalic reflex, which is also known as rotational nystagmus. In a normal vision amblyopic patient will have a normal rotational nystagmus. With a doll eye phenomena would be normal. In other patients, if you swivel the child or you rotate the head from side to side, which is a normal doll's eye phenomena, this nystagmus would keep on occurring. It would not disappear. In a normal patient, it should disappear within a few seconds. This you can also do it. 4-prime diopter test to test diplopia. We are shortage of time, so contrast sensitivity I already told you. Thank you very much.